Good morning, everyone, and it's my pleasure to introduce Dr. Mohamad Alutaibi. Dr. Alutaibi came to us from uh, Saudi Arabia, so he had done his medical school, obtaining his MD or MBBS at the Abdurrahman bin Faisal University in Saudi Arabia, Daman, in 2019. For the first 2 years after his medical MD degree, he was in a pathology residency program at the famous King Faisal Specialist Hospital. But in 2021, when he marched to our program, he relocated to the US and he has been a resident in APCP since 2021. Dr. Alutaibi's leadership role has continued to develop, especially since he moved here in 2021. So currently he's a member of the LMP, our department DEI Inclusion Committee, and is also a junior member on the DEI Inclusion Committee of the CAP. He sits as a junior member on the Clinical Practice Committee of the American Society of Cytopathology. And as we all know, he's currently one of our two chief residents at this point. Dr. Alutaibi has really shown a lot of interest in pathology in general, but he has decided to spend the rest of his career as a cytopathologist and also as a GI and liver pathologist. So he's going on to a fellowship from July this year in cytopathology right here at the university. And after that, he will go on to do a GI and liver pathology fellowships. So I think along the lines of his GI interest, he's going to be talking to us this morning on a topic of colorectal carcinoma from the anatomic pathologist's point of view, from surgical pathology point of view. So thank you. Mohamad, over to you.
Thank you very much, Dr. Day, for the kind introduction. And good morning, everyone, and thank you for joining us today. So I decided to choose this topic, although probably if you got the invitation from Amy also was just colorectal cancer, but I decided to make it as colorectal cancer from surgical pathology point of view, just to raise awareness about some of the issues that pathologists might face, especially junior pathologists. So without further ado, start. So I have nothing to disclose related to this topic. And about the objectives, so my objectives for this presentation is to understand the pathophysiology of the disease, discuss the area of possible errors that the pathologist might come into, discuss the role of pathologists in the treatment options of the disease. So colorectal carcinoma is the third most common cancer diagnosis in the world and the United States. It is the second common cancer-related death in the United States. Its incidence is 40.7 per 100,000 patients, and the death is 15 per 100,000 patients in male, and females is 32 per 100,000 patients, and death is about 10.6. And sadly, 20% of patients, when they present to the hospital, they usually have a metastatic disease. So just to show you the data collected from 2023, which it's a projected data, and as you can see here, still the colon and rectum still holds the third spot in most common cancer, and while talking about the death related to colon cancer, it's still third in males, while it's in the fourth in females. So let's talk about good news. So the colon cancer has been decreasing in incidence since the 90s. As you can see here, in the year 2000, it was about 70 per 1,000 patients, but now it's decreased to about, as I said earlier, 40. And so there is about 35% reduction since the 1990. But unfortunately, there is an increased incidence in young age patients. It used to be 8.6 per 100,000, but now it increased to 13.1 from data collected in 2016. So this reduction in number of cases did not come from nothing. It was all a result of the colorectal cancer screening programs. And as we all know, colonoscopy is still the gold standard for diagnosing colon cancer. It holds a lot of pluses compared to other methods, as it is diagnostic and therapeutic at the same time. And then we have the Cold Guard, which is the stool DNA testing. We have also the fecal occult blood test and CT colonography. And lastly, cell-free DNA blood test, which I discussed earlier this year or last year in a journal club. So talking about the pathogenesis of colon cancer. So as we all know, it all starts from a small adenoma. So some event happens that makes some mutations in the epithelium, which lead to a development of small adenoma. The adenoma will grow larger and larger until it gains enough mutations to become a higher grade adenoma, and then can invade, making the diagnosis of adenocarcinoma and lastly metastasize. So because everything starts from polyps, I thought about talking about polyps at first and see the pathogenesis of how polyps occur. So when we talk about polyps in the colon, specifically epithelial polyps, we can put them in two big buckets. We have the conventional adenoma and we have the serrated lesions. So they put the conventional adenoma just to differentiate between it and the serrated lesions. So let's start with the conventional adenoma. So it is probably the most easiest diagnosis for PGY1. As you can see here in this picture, we can have this elongation of the nuclei of the neoplastic cells, and also sometimes you can see apoptosis and mitotic figures. So talking about the types of adenoma, we have three types, which is tubular adenoma, we have tubular-villous adenoma, and villous adenoma. So tubular adenoma and villous adenoma probably are easy to diagnose under the microscope, but tubular-villous still an area of debate. There's a lot of people talking about what is the cutoff to call it a tubular-villous. So for now, at least in the WHO, they recommend having 25% or more of the adenoma having villous architecture. So the interesting thing about conventional adenoma, as any other polyp, they usually are asymptomatic and detected on colonoscopy. The polyp usually they bleed, and that's why we can detect them using occult blood testing. And there's an interesting syndrome called McKittrick-Wheelock, which is basically a large distal villous adenoma that causes secretory diarrhea. It's a very rare syndrome. The only reason why I put it here just because I saw one case when I was doing cytology, and I thought about bringing it here just to remind ourselves that this is one of the reasons of patient having diarrhea with unknown etiology. So when we talk about adenoma, we have to differentiate if it is an advanced adenoma or not. For the most part, it's usually related to the clinicians, but usually if the adenoma is more than 10 millimeter or 1 centimeter, or it has tubular villous or villous architecture, the presence of high-grade dysplasia in the adenoma, and the presence of intramucosal carcinoma. If we have any of these, that's considered as a high risk for these patients, and that warrants further management. So how what drives the development of conventional adenoma? It's still we have the adenoma carcinoma pathway. So we still think APC mutation is probably the triggering event in the development of adenomas, and then later on they'll have KRAS mutations, and one of the mutations that might happen is SMAD4, and later in the disease they develop TP53 mutation. So the other bucket, which is the serrated lesions and polyps, it is one of the characteristics of this lesion is having this sawtooth appearance on the surface, as you can see here. This kind of lesion was diagnosed or was discovered first here from our department by Dr. Snover, and we love the term sessile serrated adenoma. However, the WHO do not recommend using that title, and they prefer using serrated lesion instead. So these are just the serration if you have not seen them. Just like the other, the conventional polyps, they usually are asymptomatic and they rarely bleed. And what that means to us is that because there's no blood in the stool, so all stool testing that depends on the presence of blood is going to be useless in diagnosing ulcerated lesions. And the other thing is CT colonography is not an ideal way to diagnose these lesions. So for currently, the only two or three methods to diagnose this is by colonoscopy or stool DNA testing, or by cell-free DNA testing. So in the WHO, they have a few subtypes under the serrated lesion polyps, starting with hyperplastic polyp, which has two subtypes, the microvesicular and the goblet cell rich. And then we have the sessile serrated lesion. Then we have same SSL with dysplasia. And we have traditional serrated adenoma. And in case we can't really tell for sure which one is which, we can use serrated adenoma unclassified. So this graph I got from the WHO, and the only reason why I'm bringing it here because I think it's an excellent graph showing us how the serrated lesions develop. So basically, we have two main pathways. We have the KRAS pathway, which some people say it will result in development of goblet cell hyperplastic polyps, although there's some debate here. And then later will transform to traditional serrated adenoma, and then gaining more mutations in the Wnt pathway and TP53 mutations, resulting in a high-grade dysplasia followed by cancer, which is usually an MMR proficient. And the other half of the adenomas are BRAF mutated, and as you can see here, the BRAF can result in microvesicular hyperplastic polyp, and then this can develop into sessile serrated lesion, and the sessile serrated lesion can either go and develop or become BRAF mutated traditional serrated adenoma, which later become which later will develop high-grade dysplasia and then cancer, or the sessile serrated lesion can have some abnormality in MLH1 or Wnt activation, which lead to MLH1 deficient sessile serrated lesion with dysplasia, which will result later in BRAF mutated MMR deficient carcinoma. For the main part in our clinical practice, we do not do MMR, which is mismatch repair immunohistochemical stains on polyps. We only use them on carcinomas, but it was an interesting thing to discuss here. So moving forward, after the polyp fully develops and having high-grade dysplasia followed by invasion, we can call it now colorectal carcinoma. And in this talk, I'm just going to talk about carcinomas only. So I'm not going to talk about neuroendocrine cancer, neuroendocrine tumors, and mixed neuroendocrine carcinoma. So when we talk about colorectal carcinoma, usually the majority of these cases will arise from the adenoma carcinoma pathway. And then the remainder of them will have either the hypermutated pathway or the ultra-mutated pathway. So, the mechanism in which the polyp will eventually become a carcinoma, we can put them in three main subcategories, which either chromosomal instability, microsatellite instability, MSI, which is considered as hypermutant, or defective proofreading polymerase, which is ultra-mutant. So let's discuss the genetic changes further in this in the colon cancer. So when we talk about the first pathway, which is the chromosomal instability pathway, usually think of it as they progress from a traditional polyp or traditional adenoma. So they'll have the same mutations that we expect to see in a traditional adenoma. They'll have APC, KRAS, P53, SMAD, and PIK3CA. Usually, as I mentioned before, TP53 is a late event, and that we can see it in cancer, and further mutations in TP53 might result in metastasis of the disease. And these mutations can be seen in about 84% of colorectal carcinoma. And then we have the hypermutant pathway, which correspond to about 13% of all cases, which is usually a mutation happening in MLH1 and MSH2. And lastly, we have the ultra-mutated pathway, which has the poly mutation and correspond to about 3% of all adenocarcinoma. So in this talk, I'll mainly be talking about the MLH and MSH2 mutation. So in the WHO, they have 10 subtypes under the colorectal carcinoma. If the carcinoma does not fit in any of these, we can call it adenocarcinoma, not otherwise specified, NOS. And these types, as you can see here, we have starting with serrated adenoma, serrated adenocarcinoma, adenoma-like adenocarcinoma, micropapillary mucinous, poorly cohesive carcinoma, signet ring, medullary adenocarcinoma, adenosquamous, and carcinoma undifferentiated NOS, and carcinoma with sarcomatoid component. Although we have a lot of subtypes here, but according to the WHO and literature, probably the only one that is a poor prognosis by itself is the signet ring cell carcinoma. All the other patterns or all the other subtypes, they can have some poor prognosis if they have specific features. So I'm going to talk about a few of these lesions or a few of these subtypes briefly, starting with the serrated adenocarcinoma. As the name implies, we'll have the tufting or serration of the epithelium, which is usually they have the well-preserved polarity with abundant cytoplasm. So there's a picture here, as you can see, and usually they do not have the same necrotic material that we see with the adenocarcinoma in OS. And the mutations in this cancer, we can see similar mutations that we can see in serrated adenomas like KRAS, which is seen in 45% of these lesions, BRAF in about 33%, MSI high about 18, and MSI low is 81. And interestingly, so there's a lot of authors suggest that this is probably an overdiagnosed entity or subtype. And the reason for that is these tumors behave the same way as conventional or adenocarcinoma NOS, unless if they have GNAS mutation. If they have GNAS mutation, they're considered as poor prognosis. So that's for that reason they think it's probably an overdiagnosed, and maybe they have GNAS mutation that we can consider it as serrated adenocarcinoma. But we still have we need further studies to confirm this. And then we have the micropapillary adenocarcinoma. So just like any other micropapillary carcinoma, we can see these small clusters of malignant cell, and usually they form this like a pseudo-vascular space, which makes it extremely difficult to tell if there is lymphovascular invasion or not. And what even complicate things more, these tumors are infamous for having lymphovascular invasion and lymph node metastasis. And to call it micropapillary adenocarcinoma, you need to see more than five or more than five of the tumor forming macropapillary architecture. It is in a single center. They said they found about 5 to 20 of their CR colorectal carcinoma. They, as I mentioned just now, they frequently metastasize to lymph node. So for us as pathologists, that means whenever I see this pattern, be extra careful looking at lymph nodes to make sure there's no a small metastasis that you missed. And these lesions or this carcinoma is known for having higher frequency of TP53 mutation. And then we'll talk about mucinous adenocarcinoma. As the name implies, we're going to see abundant mucin or pools of extracellular mucin. And to call it mucinous carcinoma, you have to see malignant epithelium floating within the mucin, and the tumor has to be composed of more than 50% of a mucinous feature. If it contains less than 50%, we can call it adenocarcinoma with mucinous features. It's reported to be about 5 to 20% of all diagnosed colorectal carcinomas. It does not have any prognostic differences compared to adenocarcinoma NOS, but the only issue with this tumor is that it usually responds very badly to systemic therapy. And usually it's associated with MSI pattern. And then talking about signet ring cell carcinoma, which is one of the a famous tumor that we show to medical students. To call it signet ring in the colon, you need to see more than 50% of the tumor cells forming, having single cells pattern with abundant intercytoplasmic mucin. So as you can see here in this picture, there's all these signet rings floating in mucin. So this is actually an interesting case that I got from our teaching set on PROSHA, which shows both signet cell morphology and mucinous morphology as well. So fortunately, it is estimated to be about 1% of all colorectal carcinoma, because it is by itself has a bad prognostic factor. And this tumor, we have higher instance of MSI, and also it's been linked to Lynch syndrome as well. So medullary adenocarcinoma, this is one of the tumors that we like to show our residents and students just because it looks very blue on the microscope. And it's basically consists of these sheets of malignant cells, and it looks high grade in nature, and has prominent infiltration by lymphocytes, which sometimes referred to as tumor infiltrating lymphocyte or TILs. So this tumor by itself is, multiple authors think it's probably an underdiagnosed entity, and correspond about 4% of colorectal carcinoma, and it is considered as a good prognosis when it's diagnosed. And for us pathologists, you have to be careful that these tumors can show loss of cytokeratin 20 and CDX2. So This makes things a little bit more complicated because the tumor itself is poorly differentiated, and on top of that, if you do CK20 to make sure that it is actually from the colon, it's going to be negative and will make you scratch your head on what to call it. But the good thing is, because one of the other differential is neuroendocrine carcinoma, these tumors usually do not show any neuroendocrine marker expressions. And they usually are MSI. They have MSI high usually with BRAF mutations. So this is just the summary of all the, not all of them, the majority of the subtypes of adenocarcinoma in the colon. The only one that I guess I did not talk about is the adenoma-like adenocarcinoma. And the only thing that, as pathologists, we need to know about is that it's difficult to diagnose it on biopsy just because it looks like an adenoma. Usually it has pushing border kind of infiltrative edge. So when we talk about staging of colon cancer, we follow the TNM staging, the tumor, lymph node, and metastasis. So just looking at the table, summarizing all the T stages, there's a description and explanation, and probably description and explanation, they look the same. I just put it this way, so just a different way for us to understand what's going on in this. So colon cancer happens in a hollow organ, so we mainly follow the depth of invasion. So we have to remember your histology. The first stage is TIS, which is carcinoma in situ, which means that tumor is still within the epithelium and lamina propria and did not go through the muscularis mucosa. And then we have T1, which is the tumor goes beyond the muscularis mucosa into the submucosa. And then we have T2, which is the tumor goes to the muscularis propria, and T3, the tumor goes through the muscularis propria but does not reach the peritonized surface. And then we have T4A and T4B. T4A, if the tumor is attached to the visceral peritoneum, and B, if it involves adjacent organs. So I guess for trainees and residents, there's an important thing that you have to keep in mind whenever you gross a colon or whenever you try to write up a colon cancer report, which is the anatomy of the colon. So this picture, I took it from our gross manual, just for us, for you, in case you need to go back to it, you can find it and understand what's going on here. So the colon it has a weird relationship with peritoneum. We have some parts that are covered with peritoneum and some parts that are retroperitoneal. So as you may remember, we have the cecum, the transverse colon, and transverse colon, and part of the sigmoid covered in peritoneum, and the rectum as well. It has in the upper third has peritoneum on the anterior and lateral sides, and then in the mid third has peritoneum on the anterior sides, and then the lower third does not have peritoneum. Why that matters to us? It matters to us because there's a big difference if the tumor actually reaches the peritoneal surface or it just goes into the fat. So if it is a retroperitoneal part of the colon, let's say, for example, a right side, the ascending colon, for example, if the tumor goes beyond the muscularis propria and goes into the fat posteriorly, that means that the tumor is in the fat. So that's a T3 diagnosis. It cannot be a T4 there because there's no peritoneum there. It might go and attach to some other organs, which makes it T4B, but it cannot be T4A. That's a very important note because if the tumor is there and you can see it on the surface, on the posterior aspect of any of the ascending or descending colon, that means the tumor is a T3 with a positive margin. And this is a very important concept, and that's why even the CAP, they have a picture here explaining this to us. So if you can see on the left side, we have the peritoneum on the wall, and as you can see here, if the tumor goes all the way into the peritoneum, that means it's a T4, T4A. But if this is a retroperitoneal organ and goes on the posterior aspect of it, or if it is the rectum, any circumferential margin, and you see the tumor on the nth margin, supposedly, it's going to be, as I said, T3 with a positive margin. If you're going to take anything from my presentation, probably this is the only thing that I want to take from my presentation. So then we have the N staging, which is fairly simple. If it's N1, we have N1A, if it's one lymph node, 1B, if it's 2 to 3, and we have 1C, which is the tricky one for us as pathologists, because N1C, that means there's no positive lymph nodes. However, we see tumor deposits, and tumor deposit by itself is a prognostic marker, so we have to be extra careful. If you see any tumor within the fat in the same vicinity of the lymphatic drainage, but there's no evidence of lymphatics or lymphoid tissue that resembles a lymph node, then you can call it tumor deposit. But the good thing, it's not a good thing, it's bad for the patient, but whenever there's a lymph node metastasis, we cannot use N1C. But however, still in the CAP protocol, or College of American Pathology protocol, you have to report it. And then we have N2, which is N2A, if it's 4 to 6 lymph nodes, and N2B, if it's more than 7 lymph nodes. And lastly here, we have the M staging. It's for metastasis. Just remember here in the colon, we have only M1. There's no M0 and there's no M2. So M1, the way I see it is there peritoneal involvement? If there is peritoneal involvement, regardless if the tumor metastasizes to any other place, it's going to be M1C. If there is no peritoneal involvement, then it depends. If it's just single organ, it's going to be M1A. If it is 2 or more, it's going to be M1B. So talking about the treatment here, there's this issue that sometimes us as pathologists might run into, which is having a tumor that is completely within a polyp. So in the surgical treatment, which is usually the way we approach the colon cancer, because surgical treatment can be curative in some cases, and the treatment of colon cancer it's getting more and more complicated, but I'm just going to talk about this part of it because it involves us, and it can show you how your report might change the patient's life. So the question is, if there is a polyp, or the tumor is a polyp, if it is yes, then is it a malignant polyp? A malignant polyp is defined by having tumor that is more than T1, so T1 or more. So in situ component does not count here. If there is no polyp, but there's cancer, there's some guidelines for colorectal cancer. But if there's a polyp and there's cancer within the polyp, then as pathologists, we're gonna run into two situations. Either the specimen is intact, it's either the endoscopist removed the lesion entirely, or they did an endoscopic mucosa resection, EMR. In that case, if the specimen is intact, then clinically they're going to see if there's a pedunculated polyp, which means that probably they removed the entirety of the polyp, then they're going to observe. But if it is a sessile polyp and they might be afraid there's some residual tumor, then it's going to be a joint decision between the treating physician and the patient to decide if they want to observe and see or go ahead with colectomy. But to call this here we have to make sure that there's no unfavorable histology, which I'm going to talk about in a second. So the other situation that we might run into, which is kind of frightening to be honest, which is we're receiving a fragmented specimen. Because when you get that, the question is, can you assess the margin? Because if the margin is positive, that means they have to follow they have to go and do a colectomy. But if it is negative, then they can just follow the patient and follow the intact specimen guidelines. But if we receive it fragmented and we have some unfavorable patterns that we see, including lymphovascular invasion, or the tumor is very close to the what we think it's a resection margin, or if the tumor is high grade and it's not high grade is either G2 or G3, any of these, as the current recommendation is to go ahead with colectomy. So just whenever you're gonna make this diagnosis, just make sure that your diagnosis is correct, because this can change the patient's life from just having an endoscopic procedure and they're done, or can go into colectomy. And that's why it's kind of a very tricky situation. So now I'm going to talk about stage 4 colorectal cancer. And the only reason I'm going to talk about this, because if you look at the statistics, we can see if the tumor is localized, it has a very good 5-year relative survival rate. And if it is even regionally spread, still considered as a good prognosis generally. But once there's a distant metastasis, it drops severely. So this is an kind of dilemma why this happens, and what the options that we have to treat these kind of cases. So a lot of literature came out talking about this. Probably you've heard a lot about them, but I'm just going to talk about a brief possible mechanism that are discussed in one of the articles that I thought were very interesting, and they have some actionable or possibly actionable ways in the future. So in one of the studies, they tried to do a next generation sequencing NGS on the primary tumor and the metastasis, and they did not find any significant mutations, and that's why the current guidelines does not recommend having running NGS again on metastasis, unless if the patient has been on the treatment and then suddenly they came to the hospital with metastasis. That's a different situation. But when they did NGS on metastatic cancer, they found that about 60% of them, they have TP53, and they have a lot of TP53 mutations, so it's not something specific. And each of the and in one of the studies, they said that some specific TP53 mutations are makes the tumor behaves in a specific way, but I'm not going to go in depth in that right now. And usually the metastatic tumors, they have higher mutational burden, and sometimes they can express HER2. So one of the interesting things that still here in the literature is the epithelial membrane protein 1. The interesting thing about this is if the patient came with a colon cancer and they resected the colon, and then later they came to us with a recurrent disease or metastasis to the liver, usually the liver metastasis will have this epithelial membrane protein 1. So this could be a targetable targetable mutation. We can deal with some mutation. And then we have the epithelial mesenchymal transition, which is another fascinating, talking about cancer, it's kind of interesting mechanism that colon cancer can do, which is basically the tumor will behave as a mesenchymal cell, which gives them more mobility to metastasize. So in other tumors, we have this as a true phenomenon. However, However, in the colon cancer, they have this interesting mechanism in which they actually hide their or internalize their epithelial markers, which leads to the tumor cells behaving as a mesenchymal cells. The AMT is another possible target for the future, but still the research on these two, the AMP1 and AMT, is still undergoing. So as we just saw how the stage 4 cancer is devastating, it's basically a lethal disease. So we have to talk about the treatment options that we have. So in the past, the only treatment that we can offer to them is systemic chemotherapy, which means basically probably they don't need pathologists to do that. But nowadays we have a lot of targeted therapy, like for angiogenesis or for EGFR inhibitors like cetuximab, and then we have the immune checkpoint inhibitors, which could be targeting PD-1, PD-L1, or CTLA-4. And as I just mentioned, that sometimes the tumor can express HER2, which means we can actually use HER2 medication. But interestingly, dealing with colon cancer, they usually do not respond to a single HER2 targeted therapy. So usually have to have them in combination to their trastuzumab and lapatinib, or trastuzumab and pituzumab. But this is, I believe, it's still recent. There's still some studies going on that on this part, so we might say some advancement in the future. And then we have the vascular endothelial growth factor, VEGF inhibitors. These are a few examples of them. And somewhat it talks about the CAR T cell therapy, and is it going to be is it going to play a role in metastatic colon cancer? And I believe we had a journal club, I don't know, but 2 years ago, and we talked about CAR T cell and solid tumors and why it's difficult, because mainly they have a lot of antigens, which makes it and a lot of mutation, which makes it difficult if we compare it to hematological malignancies. But it is still some people are still doing research on that, and hopefully we're going to see we're going to hear some good news on this topic. So for MSI high, which is microsatellite instability high colon cancer, we can use immunotherapy, which is basically the famous one is pembrolizumab. And in one study, they tried to compare it with chemotherapy in patients who had MSI high and deficient MMR proteins. And in that study, there was fascinating differences in progression-free survival. And patients who received anti-PD-1, they have 16.5 months compared to 8.2 months in patients who received traditional chemotherapy. So because of this result, actually the FDA now has the anti-PD-1 agents as the first-line treatment for any patient with MSI high colorectal cancer, and they have deficient MMR. So if any of the residents is wondering why we do MMR testing on all the colon cancer we get, it's because of this. If there's an MMR deficient tumor, that means there's a targetable or something actionable we can do to help these patients. So if you were paying attention about my presentation, I talked about microsatellites a lot here. So what exactly microsatellite? It's short tandem repeats in the genome. They have several short unrepetitive DNA sequence. And since there's a lot of or several short repetitive DNA sequences, that means mistakes can happen. And that's why we need the mismatch repair enzymes to fix that. So if you have if you have a broken MMR system, that means all these microsatellites short tandem repeats will continue to grow and make very long DNAs. So that's why we use MMR immunohistochemistry as a way to tell us that probably there's an MSI high or MSI low, and that's why we when we report them, we give the probability of this having an MSI high tumor. So for us as pathologists, the main reason why we care about this is because we're gonna, if there's a microsatellite instability, that means we can offer the patient immune checkpoint inhibitor. So if you remember, we have the four immunohistochemical stains: MLH1, PMS2, and MSH2, and MSH6. So now we just talked about microsatellite instability. Then there's another thing, which is the tumor mutation burden, or sometimes they call it tumor mutational burden. So it's basically the total number of somatic mutations detected per million bases. And this is another way to figure out if the patient might respond well to immune checkpoint inhibitors. So here we reach to this question: is there a difference between TMB high versus TMB low in colorectal carcinoma? So this question was raised by Dr. Zhang. So we decided last summer to actually try and figure out if there's actually some differences. So we gathered all the cases that had NGS testing run on them on the year 2023. And then we have the TMB calculated, and we use the oncogenic derived mutation and germline alternation based on the MOMAD and DPSNP databases. And we set the value of we define tumor mutational burden high as having 11 or higher mutations, which is, thankfully, we did not have any cases that actually fall on this number, so we were actually lucky in choosing that. But if you read in the literature, a lot of articles, they set TMB high at 10. So we're kind of close to that. So talking about the result of our study, we had 76 cases with who had NGS testing done on them. 18 of them had TMB high, while 58 had TMB low. So just a brief summary on the result we found. As you can see here, we have the MMR status was significant, as you can see here, as the tumor low. Usually they show they can show intact expression, while the tumor high we saw some loss of expression of MMR. But the interesting thing here is we have 7 patients who had intact MMR expression, but at the same time they are in the TMB high category. So does that mean these patients we could have offered them immune checkpoint inhibitor? So that's one of the findings that we found here in our study. So talking about other findings that we had, the TMB high was more on the right side of the colon, while TMB low was on the left side of the colon. This is a known thing that has been documented in the past. And talking about the histologic type, the majority of TMB low had adenocarcinoma NOS, while some of the special types we had, like mucinous features, with the more associated with TMB high. So usually, if there's multiple primaries happening at the same time, usually the tumors, at least in our study, showed that they have TMB low, and TMB low was associated more with lymphovascular invasion and perineal invasion, 2 of which are considered as bad prognostic factors. And then the TMB low cases had metastasis to lymph node more than the TMB high. And for distal metastasis, TMB low had more distal metastasis compared to TMB high. So the limitation of our study, it's a retrospective study. So we had all the limitations that we can't find in retrospective study. We had a lot of information that we're missing, so we had to erase some more data. And the other thing is we have a small population, but we only collected data from 1 year. And the other thing is the inconsistent collection of samples. This is my opinion, because some patients were diagnosed in 2016 and then they presented in 2023 with metastasis. However, they did the NGS on the prior excision that was done in 2016. So the patient already had some treatment. They might have some different mutations happening. So prospective study might be more helpful in this case. So what can we do next with this study? We can increase the study sample, which means reviewing more cases, and I can discuss that with the co-authors and see if we can do that. And the other thing, because we have 7 patients who had TMB high but had proficient MMR testing, we can actually review this and see if that was real retained MMR expression or not. It was not done in the colon cancer, but in other cancers, they actually noticed this phenomenon because MMR testing is basically done based on looking at tissue and sometimes can be subjective. So in other studies, they speculated that probably this discrepancy between TMB high and MMR testing probably due to inter-observer variability. But they did not prove it with numbers, so we can check with these cases and see. This project was submitted for ASCAP 2024 and got accepted for as poster presentation. And I would like to thank all the people who helped us with this, starting with Dr. Rayan Martinez for the help of helping pulling the cases, him and the molecular team, and Ariba Rizvi for helping with the data collection, which was a lot, and all the people who helped us writing up the abstract, and Dr. Zhang for the idea in the first place. I can't finish my talk without showing my cats. So these are my 2 little cats. One of them is a potato here. And if you know me, you probably know that I have a succulent plant that's been following me whenever I go, which is Mr. Piney. And I just gonna let you know that Mr. Piney is still alive, but he's on a sabbatical back home. These are my references. And before I open the floor for questions, I just want to thank all the people who I worked with in the past 3 years and a half. It's been a great experience. I'm glad that I chose this program. Thank you all for for all the teaching that you gave us in the past years. And a special thanks for Dr. Dolan, Dr. Johnson, Dr. Zhang, Dr. Khalifa, and Dr. Aday for their guidance throughout the past 3.5 years or 4 years. So with that, I still have 6 months before the end of my residency, but I'm gonna stick around for 2 more years. So now I'll open the floor for questions.
Wow, thank you very much, Mohammed. You presented this as a pro. One would think that this is giving talks is what you've done for the last 20 years. So that was really well done, well put together, well organized, and really, even as a GI pathologist, I learned I learned a lot. So that's very good. Questions, comments? I see that Andy Nelson has one.
Hey, everybody.
Andy always has one, so don't worry.
It should be easy, Mohammed. Question on your 7 in your study. What was the TMB range for those that were classified? I agree with kind of your cut points, and we could get into commentary on some of that, but just interested to know for your cases that were proficient MMR, what the range of TMB was for them.
Well, I unfortunately do not remember exactly what was the number for that case, for these 7 cases, but I already decided I'm going to do that. I'm going to pull the cases, but after I do my boards, I'm going to pull the cases and review and see what's going on with these 7 cases. But exactly, I don't know what the exact numbers. Yeah.
So here's kind of the guidance for you, and come find Ryan and he can help you since he's an author on the paper. So, again, look at that range. Within colorectal cancers, TMB elevations in what we kind of call an intermediate range, so that 11 to 16 to 20-ish, those are not uncommon. Those are usually not associated with microsatellite instability, and the impact in terms of checkpoint inhibitor outcomes is somewhat limited or somewhat dubious, just based on the way Keynote was done and some other studies with some other IO agents. And then if there are ones that are elevated above 40, 50 mutations per megabase, let Ryan and I know. We can go on a search for your 3% of POLE mutants.
Yeah.
Thank you very much for your comment.
Yeah, and I think, Mohamad, that's also another question that you probably want to expect in Boston, because once you point out those 7 cases, the next one is going to be what is the range. So if you can find that data before you present it, that will even be better.
I will put that in the poster.
Yeah. Any other question, comments? Okay, so thank you very much for saying that. And I don't think Drew is here, because I want to just recognize some of Drew and the PA's input here. Mohamad was able to show some of our gross manual things, and this is just a very good, excellent resources that our PAs have provided, and they continue to provide just to make life very easy for all of us. So on that note, I want to thank everyone for their attendance, and I know that we should be logging into Dr. Rachila's QA talk in a few minutes. Enjoy the rest of the day.